Hello. Okay. Hi, everybody. So I'm BJ Miller, palliative care doc. Here to respond to questions we didn't quite get to in the webinar we just did this morning, the webinar on advanced care planning. By the way, you can find that webinar and all the other ones we've done on our website at mettlehealth.com or on our YouTube channel. Okay, I've never said that before. That sounds kind of funny. Okay, so all right. So Sonia, over to you for the questions, please.
Did you want to start about how
Oh,
inherently confusing
yeah,
advanced directive
yeah.
planning
You know
is?
what?
Just a quick note.
Sorry, sorry. Thank you. Yeah, I just want to say something about this morning's webinar was a little frazzled because of some technical issues, but that's not all that's going on. If you feel a little confused by this subject or by the presentation on this subject, that's makes a lot of sense. This is an inherently confusing process. It's a very clunky process, again, to project yourself into some future state that you can't quite, you can't quite know now, and to project what you wish for your care at that future date. It is fraught, and then there are the legal distinctions between POLST and advanced directives, and where they're legally binding and where they're not, where they're just suggestions, where we're relying on morality or bioethics, not law. I mean, it is fraught. So if you're confused, welcome to the club. There are efforts to continue to refine this process and get clear from the policy level on down to sort of how the forms themselves. So please don't give up on this process. It's all we kind of have to protect our wishes in some ways. But if you're a little confused, that makes a ton of sense. Okay, so with that caveat, yeah, thank you, Sonia. Back to you.
Okay. So this first question has a little bit of a story around it, so I'll just read that and then get into the question. My father is now in a care facility with dementia, and we have an advanced care plan, which was developed with my dad in his early diagnosis. Advanced care planning is something we feel quite passionate about since my mom died 16 years ago and spent her final week unconscious in the ICU. My dad is now in moderate advanced stages of dementia, so ICU is something we are keen to avoid if possible. My concern is around emergency treatment for a potential fall and, say, a broken hip. My dad has requested no life-prolonging treatment or medical procedures, and that all life-prolonging treatments be stopped and he receive palliative care. It is often hard to stop the medical process once a patient is admitted into the hospital system. Do you have any advice around emergency treatment, how to deal with medical emergencies, and how to handle this when filing or filling out an advanced directive care plan?
Great questions. And thank you for your advocacy implied in this question. So it sounds like you guys have learned a lot from your situation with your mom and want to do a little different with your situation with your dad. So amen, right on. So now to your question. So if dad, for some reason, you know, ends up in the ER, like falls and breaks a hip, right? So he's in a care home, I'm assuming on the frailer side, and breaking a hip happens pretty dang frequently. And so that's a situation where you find yourself pretty quickly to the ER because just the pain alone is going to need to be addressed and imaging to figure out what's happened, et cetera. So making sure that the care facility, requesting the care facility be sure to send a copy of an advanced directive with the admission paperwork, with the transfer paperwork. You yourself as a family member bringing that advanced directive if you have a copy, or representing it faithfully to the doctor. A lot of doctors aren't going to need to see the paperwork. If you are clearly the next of kin or clearly the family member who's trusted by the patient, oftentimes they won't going to need to see all this paperwork, but still bring it with you if you have it. That will help. And then in that situation, you might in the ER, let's say they get a X-ray or whatever else, and it shows a fracture of the hip, and then it's a question of, well, surgery or not surgery, not to prolong his life, but surgery for comfort or the ability to walk again. This comes up not infrequently. Of course, surgeries will still have their risks, but it's not conceived to, this would be a surgery potentially to help his quality of life, and therefore might qualify under his previous stated wishes and your wishes as a family. That's something you want to pursue. So in that case, when a sort of unplanned but important surgery crops up, sometimes the surgeon will ask you to revoke the old advance directive, agree to a full code for the procedure itself. And then once through the procedure itself, so if something happens on the operating table or whatever else, that they can resuscitate them in real time during the surgery, or correct what's going on with the anesthesia or whatever else. So sometimes I'll ask you to revoke your DNR, agree to a full code just for the surgery, and then once after the surgery, you can make sure to follow up and make sure to go back to DNR. If the surgeon, you can talk that out. You might say to the surgeon, hey, if his time comes during the surgery, that's okay. That's still with his wishes. That's him. We should allow that death to happen. He still would not want to be resuscitated, even when pursuing a procedure for quality of life like this kind of surgery. The tricky here is the surgeon may or may not agree to that. Many surgeons won't, for all sorts of reasons, including they don't want people dying on their operating table. It can come down to that for their mortality risk, their own. Doctors get graded on intraoperative mortality. So that may sound like a pretty lame reason to do anything, but it's a real reason for the surgeon and others. So it gets hard. If that surgeon's unwilling and you really feel strongly about it, you might say, is there another surgeon in your practice who might feel comfortable doing this? But eventually you may be pushed to, so either if you want the surgery, we got to revoke the DNR, just make sure that right after the surgery, you get the DNR reinstated. And that's a communication moment. And then was that everything to the question, Sonia? Was there more to it?
I think so. Let's see. I think understanding how to mitigate, types of care that aren't wanted when coming up against a medical emergency.
Yeah. Well, so that I sort of drilled down on a specific thing like a hip fracture, which is so common. So, but other things may come up that don't require surgery, but that gets the whole medical apparatus all wound up, or the nursing home wants to send dad back to the hospital, or whatever's going on. So the extra layer of support, the extra thing you as a family can do around protecting dad's wishes here would be to add a POLST to the mix. And in advance of the emergency, and during an emergency, it's not a time to fill out a POLST. It's just not really feasible. Excuse me, feasible. So adding a POLST to the mix, adding that doctor's signature to a form, and being very clear about this, that will help protect your dad, much more legally binding than an advance directive. So even if he makes his way to an ER or whatever else, if that POLST travels with him, and especially if your dad is seen consistently in a same health system, that's the ER he might go to, make sure that health system, his other doctors, have that POLST form, have that advance directive, and that it's uploaded into their health system, that it's documented in their computer system and therefore accessible. That will help protect things, because then in ER, no matter what's going on, it'll come up in your dad's chart if it's his local hospital. So otherwise, if it's not a local hospital or whatever else, make sure to make sure that POLST goes with him on the gurney to the hospital. And also, you can also talk to the facility and say, hey, no matter what happens here, guys, we do not want to go back to the hospital. If there's an emergency, we want to immediately enroll in hospice and help him die comfortably, for example. So that can be meted out in a conversation with the facility in advance of an emergency. But during an emergency, there's really not much time to do that. So then last point here, guys, is you can, irrespective of whatever health system dad's in or anybody's in, you can upload your advanced directive and POLST form to these third-party registries. mydirectives.com is an example. We'll put a list of these resources out to you in an email. But there are these third-party cloud-based secure places you can upload your wishes, and then they're accessible from anywhere. So then you just have to tell the ER where dad lands to go to this website and download his advanced directive. Okay, long answer, but complicated question. I hope there's something in there for you.
Okay. All right, next one is, can a physician refuse to sign a POLST if the patient is currently healthy, however, they have gone through a lot medically and are very clear about wanting no more medical treatment?
So a physician can absolutely can refuse to sign a POLST, no matter what the circumstances, young, healthy, old, whatever. You can't will a doctor to, because it's something of a prescription. It is a physician's order. So you can't will a physician to order anything. Your power as a patient is to say, no, you do not have to agree to what the doctor is suggesting, but you can't force a doctor to do what you want. So sure, a doctor cannot sign a POLST for any reason. That would be pretty hard to imagine, even in the young, healthy person. If that young, healthy person has a good reason behind, can convey their reasons to that physician, have a conversation about it. No reason, young and healthy, that's fine. So it'd be pretty rare I've never heard of a physician refusing to sign a POLST. I'm sure it happens. I would imagine as basic communication and conflict resolution goes, conversation can get you a little bit farther. Barring that, then you can simply say, is there another physician in your practice, or just go elsewhere looking for another doctor to sign that form. It does not have to be a person's primary care doctor or any particular doctor involved in their care. They just have to be involved in their care. It could be the oncologist, a cardiologist, internist, you name it. So good old communication will get you there. And if the doctor still refuses to sign, get another doctor.
Okay. Next question, and you alluded to this a couple minutes ago, is where do I file these documents? I have a primary care physician at one place, a medical oncologist at another, and they may not be linked in the medical record. What about insurance? Where are good places to have these documents filed?
Okay, so yeah, well, there's a little bit of a review for that first question, but right on. So first order of business would be, if you have your advance directive, right, making sure close in people, make sure the family has a copy at the ready and knows where it is, safe deposit box or somewhere in a drawer at home, but just somewhere where they know they can find it, somewhere accessible. So making sure your inner circle, family and friends, has a copy is a smart thing to do. Making sure all of your doctors who are involved in your care have a copy is a smart thing to do, especially if they're in different health systems. Just bring a copy with you to that next appointment and say, most EMRs, electronic medical records, most health systems now have a capacity to upload these documents into their system. So bring a copy to every doctor who's on your list. That would be the most prudent thing to do. It's a little pain in the butt on your end, but that's a way to be as bulletproof as possible within various health, across health systems. And then lastly, a reminder here, this yet another layer of support would be to go to something like My Directives or Join Cake, or there are other organizations. Again, we'll put a resource list out to you, but these are secure, legally protected, secure, cloud-based vaults that can store your advanced directives for you, and then are accessible by just need a password. So there, if you end up in an ER in, well, wherever, anywhere, they should, by rights, it's hard to imagine an ER doesn't have internet access, should be able to reach your advanced directive that way. You'll have to tell them about that. They won't know to look, but that's another way to, if you've done all of those things, and including a POLST form, you're about and communicated to everybody in this mix and stayed up to date in that conversation, you're about as bulletproof protected as I can possibly imagine.
Okay. Next question, also about accessing advanced directives. Do you know of a place where video advanced directives are available to medical personnel? Maybe through a link or a QR code. And do you know if it's becoming more common to do a video advanced directive?
Interesting. I don't know the answer to that question, but it sure sounds like a good idea, because these forms are inherently generic. They reflect your personality to the degree to which you can write that in. But a video, you can get a feel for the person saying, hey, I fully understand what resuscitation means. I fully understand the consequences if I avoid resuscitation. I am okay with that. I want to allow a natural death. Do not resuscitate under any circumstances, whatever it is. You can imagine a video of the person themselves saying this unambiguously could be pretty dang compelling. So I love that idea. And remember, that's in some ways that's just as legitimate as the form in some ways, because these forms, they're not so legally binding. They legally protect you naming your healthcare proxy. And then therefore, with that advance directive, with that paperwork done, the health system has to honor your proxy as they would honor your privacy. But otherwise, the wishes stated in advance directive around resuscitation and everything else, again, hospitals can find ways around these, and not maliciously, generally speaking, but they're easy to doubt, especially if they're in conflict or the dates, 20 years ago or whatever it is. There are ways to poke holes in these things. So augmenting an advance directive with a little video clip on your iPhone would be a beautiful addition. By itself, without an advance directive form per se, man, every doctor I know would be pretty hard pressed to hear a video that was recorded recently and this person directly speaking to me about their wishes, especially if family agreed all what's being said here. I'd be hard pressed to not honor those wishes, and every doctor I know would. Legally, if you've got a family in conflict saying, yeah, well, dad said that to you in that video, but to me, we didn't video it, but he said X, Y, and Z. No way. The video is just gonna, the doctor's gonna say, sorry, we don't know who to go with here, so therefore we're gonna have to go through our default channels, full code, etc. So I don't think there are legal teeth to a video advance directive any more than there are legal teeth to a paper advance directive. So there you go. But we'll keep an eye on this, because I bet there are going to be sites that are pursuing this in a more formal way, if they're not already. We'll look into that and respond on our email. Thanks for the nod. It's a great question.
All right, next one is the timing very important when it comes to advanced directive POLST DNR, as in earlier the better, or as opposed to a medical crisis?
So in a way, the more recent an advance directive or POLST has been completed to the event itself, to the time where you actually need to invoke the advance directive, it just feels better to know, like, hey, dad's in the ER and his advance directive was filled out a month ago within the context of the illness that is ongoing. It's just more believable. It's easier to have confidence in it because it's more recent versus 10, 20 years ago, before dad or mom or yourself had that diagnosis and the world may have looked different. If there is no other paperwork, we still sort of have some obligation to that old advance directive, but it would be easier to poke holes in it. So in terms of it being a functional, useful document that allows everyone to proceed with confidence, family and physicians alike, the more recent, the better. So this is why it's so great to update these things when there's any change in your health status. So a new diagnosis, or perhaps an early cancer became an advanced cancer, a metastatic cancer, or early heart failure became stage 4 heart failure, for example. Those significant medical transitions, those are great moments to re-up your advance directive, revisit it yourself, and then you can add another little date to that, like reviewed, today, May 7th, whatever it is, 2021. That's a nice way to update it, keep it fresh, but don't just do the document. Remember, within those moments, have conversation with your doctor and your family, everybody on the inner circle. Say, hey, look, I look at my advance directive with this new diagnosis and it still holds. My wishes are unchanged. Just want you to know that. That's just a smart thing to do. So yeah, I think that's the answer to the question. Did that answer it, Sonia?
Yeah, I think so. Okay, next one is, have you heard of wrongful life lawsuits for doctors not following advance directive wishes? I think you talked about this a little bit in the other discussion, but we can address it here too.
Yeah, I've heard sort of secondhand, third hand, whatever it is. I have not read about or reviewed a case, a wrongful life case, but like we discussed earlier in the webinar, I bet there have been. We should look it up. I mean, yeah, we'll put that on our homework list. I bet there certainly have been, and if there haven't been, there are sure as hell gonna be. The dynamics of the baby boomers aging, and that certain mentality and ethos that goes with that, the waning but sort of lingering of a paternalistic healthcare system. Those things are at odds. And no, increasingly, the population is not going to be satisfied with a doctor who does not obey, does not exceed the wishes of the patient. So if there aren't wrongful life lawsuits on the books currently, I bet there are. I'm sure they're coming. And I'm glad for that. That changes the math. This, if a doctor covering their tail is, well, I don't know, this advanced directive was a year or two ago. I don't feel comfortable, so let's resuscitate and then we'll deal with it later. Lord knows no one would sue us for helping them live longer, right? Well, no. Plenty of people would. As we get more and more comfortable with death, that's not the enemy here. So this is all wet concrete, and I would imagine the legal world, the tort world, if that's the right word, is going to begin to increasingly reflect this change, this societal change and expectations around the end of life.
I'll add to that. I'm pretty sure that we've read about at least 2 cases where
Yeah.
a family sued the hospital because they didn't follow the wishes of the person who was kept alive against their wishes. So it does happen, and my guess is that it'll be more frequent.
Yeah.
Next one is, if someone has early forgetfulness but is not diagnosed with dementia, can they still do an advance directive?
The answer is yes. Um, you know, this gets at sort of capacity, decision-making capacity is a sort of as a designation usually made by, so I can't remember the language. There's capacity, and there's one other word that gets thrown around this. I can't remember, but essentially, a doctor, a doctor is one who says whether or not you're thinking clearly enough to make decisions for yourself. That's a medical process. Competency or capacity. Competency or capacity. One has a legal tinge that the courts can adjudicate, and one is a medical tinge that the doctor adjudicates, if that's the right word. But either way, they get the same gist. The bottom line is anybody, your dad, someone with early forgetfulness, he still has the rights to make decisions for themselves as long as they can demonstrate insight into their situation, has some ability to track the options of what happens if we treat versus not treating. If they can demonstrate that kind of insight around this specific issue, this specific health issue, this specific decision that needs to happen, in this case, an advanced directive being filled out, then that is, that's legal, that's permissible, that is protected. All right. You might think that person, dad still might get the day wrong. He might think it's 2 weeks ago or a month ago, whatever else. But if he's got insight into illness and the trade-offs of treatment, everyone should still should honor his wishes, and that can be reflected in an advance directive. The bigger point here, though, really is it's not so much a legal thing, because an advance directive, again, it's more sort of medical suggestions. But if you got a family who are at odds with that advance directive, even if it's filled out by someone who's thinking as clear as bells, you're still in trouble. And even more so, you can imagine if dad has early forgetfulness and you got 2 siblings who are on different sides of this fence. One sibling is sure dad means this, and the other one sure dad means that. The advance directive is probably not going to get you all the way there anyway. You're still going to have to talk that out with the physician in real time. So I suppose another way of saying this is anyone can fill in an advance directive. Whether family and medical professionals feel comfortable following those wishes is the question. And that gets to capacity or competency. And that has to do with whether dad can think clearly in the moment about that particular health situation. So there you go, clear as mud probably. But the short answer to your question is early forgetfulness. Yes, dad can still fill out that advance directive. Just make sure everyone's in on the communication.
And I'll add a quick note to that. We're going to include a link to an advanced directive to use when someone does get diagnosed with dementia. So filling one out at early stages, they do exist. So we'll get you a link to that. The next question is, I've had folks who had no one in their life to appoint as proxy, or worse, people in their circle did not want to speak for them. In these cases, I've helped them make a POLST. I just wanted to check in on this. Are there any cons to that? So having a POLST without an advance directive.
So, yeah. So, first of all, for folks who don't have anyone in their lives or have people in their lives who aren't willing or able to participate as a healthcare proxy, there are fiduciaries and who can legally, you can sign your sort of bits and pieces of your sort of life's organization over to a fiduciary. A court can appoint a guardian. So those are two ways that someone without anybody in their lives who can take on this role of proxy can essentially get themselves a proxy. Um, Again, fiduciary, or go through the courts and get guardianship. Each has their flavors and their issues, etc. But that's one part of your question, one answer to your question. But the other is to your more specifically, no, it's fine if you don't have an advanced directive, but you have a POLST. The POLST is the more durable of the two in a way, again, because it's signed by a physician and it's very concrete and very specific around medical intervention. So if that person filled out the POLST on their own free will, you helped them and guided them through it, and they've filled it out on their own free will, and a doctor talking to that person feels that the person has capacity, decision-making capacity, then that physician can of course sign the POLST, and that POLST should hold up just fine, with or without a companion advance directive document, with or without family members saying that yes, that's a good idea, or no, that's a bad idea, or whatever else. So the short answer is yes, keep doing that. Sounds like good, important activism, advocate work, helping them fill out the POLST. Just make sure you might want to if you can, attend the doctor's appointment with the person to make sure that that conversation you've had is reflected faithfully to the doctor before he signs the form, or as he's weighing whether he should sign the form. But once it's signed, that's good. Just make sure it's accessible. A POLST only is as good as something you have to have access to the actual form itself, whether through the medical record or through in person, for it to be active, for it to actually work. But anyway, with all that satisfied, yeah, you're good.
All right, and our last question here is, my 99-year-old dad has an extensive advance directive that essentially states, do not resuscitate unless there's a reasonable expectation of returning to a normal life. He was just in the hospital for a few days, and the hospital had him complete a MOLST, which is another way of saying POLST, where he contradicts the do not resuscitate wishes in the advance directive. He's fixated on living to 100. Do you have any suggestions on how to convince him otherwise? His cognitive abilities are failing.
Whew. Tricky business without actually talking, seeing your dad here and getting a sense of how forgetful are we talking, because he may be a little forgetful, but like we said in the last question or two, he may still qualify to have decision-making capacity or competence to make such a decision for himself. And it sounds like if someone filled out a MOLST with him, a doctor who signed it, who felt that your dad was clear enough in that transaction to warrant signing the document, I mean that will supersede a prior advance directive. Now, if you're wondering whether there was that was a haphazard process and the doctor didn't really inquire whether your dad had the capacity to make this decision, or you anyway want to revisit that MOLST document, going back to that doctor and say, hey, dad's actually pretty forgetful. Can we have that conversation again? You may have missed something. Maybe he or she, that doctor, will participate. But that document, once signed, is binding. So you may be stuck with that as a family and just sort of saying, hey, well, okay, all right, Papa, if this is your life goal to get to 100, and if that means being in a hospital, potentially something goes wrong and you're in a hospital and you get resuscitated to the point where you have a pulse, but you're on a breathing machine and stuck in a hospital ICU, if you're cool with that and that gets you over the 100th birthday finish line, okay, just got to make sure everyone knows what they're getting into. And then the question may be, Dad, okay, if we land in that horribly difficult situation and you are resuscitated and alive by some measure, but you're dependent on machines and can't speak for yourself, we should fill out a second document here that states once past your 100th birthday, then it is okay to withdraw life support, or that is your wish to withdraw life support. Because the risk here is dad could get stuck on life support, and without any document or sensitive doctor who knows the family here well, dad could get stuck in that mode indefinitely, and that could be really brutally difficult. So, gosh, it's hard to say much more about that situation. There could be a lot of variables in this mix that might tweak my answer a little bit. But the bottom line here is if dad filled out that MOLST and the physician signed it and was clear that dad was clear enough to state his wishes, and that thing is signed, well, you're kind of stuck with it. I would just make sure to talk to dad about this eventuality, this possibility that he gets stuck on life support, and be very clear what he wants you to do then, and make sure that clarity is conveyed to the doctor. But oof, tricky stuff. This is where this is inherently a risk to get to that 100th birthday. You are risking the possibility of ending up in an ICU on breathing machines indefinitely, etc. If everyone's eyes are wide open, if dad's eyes are wide open, even if he's a little forgetful and makes that decision, then you're left to support him, even if you disagree. And there you go.
All right. Thank you so much, BJ. Thanks everyone for watching.
Yeah, thank you, Sonia, and thank you, everybody. Again, thanks for your patience today. It's good to be with you. Mm-hmm.